Welcome back. Today we're going to take a look at the last part of our nervous system to be studied in this course. We're going to examine the question of memory, and then we're going to look at a few of the things that can go wrong of the many, many possibilities in the nervous system. We are going to come back to parts of the nervous system as we continue along in the course where the nervous system intersects with some of the other systems that we're going to study. Today, first, let's look at memory. Memory is something that's been studied very extensively and about which we're still new babes in the woods, so to speak, scientifically, because we haven't made the kind of progress that we have in other areas of neurologic study. Without memory, we would make repeated mistakes. We would not learn from the past. And in fact, I've heard insanity defined as repeating the same activity over and over again and expecting a different result. Now, memory helps us keep from doing that. And on the other side of that, we would not be able to repeat our successes, except by chance, if it weren't for memory. We don't really know very well, nor can we define very well, how we recall memories, how we get them out of their storage when we want them. For example, I can still remember from over 50 years ago the telephone number I had when I was a small child. It's of no value to me. It's a number that's not used, nor have I used it since. And I may not think of that number in my conscious for 20, 30, 40 years. But if somebody were to ask me, I could get it like that. Other memories I can't pull out, but where that's stored, what it's doing there, and in what form, for decades and decades, maybe my whole life, we have no idea. And how we can instantly recall it and pull it out is really an amazing thing. We have a better understanding of the acquisition of information in memory and how and where it gets stored. It's the recall we still need a lot of study on. Now we have some definitions. Learning is our ability to acquire new information or new skills by either experience or by instruction. It's a little different from memory because memory is a process of events in which that information which we've acquired through learning is stored and then retrieved when we need it, and only when we need it. There's also a term called plasticity. The brain has a very fine plasticity, and that's defined as our ability to change learned behavior when we respond to new stimuli, or we acquire new knowledge from either changes in our environment, whether they're external or internal, so that memory isn't fixed, because the learning is going to give us new memories, and we have to be allowed to change that with our changing environment. As you can imagine, this is very complex. Now, how does this happen anatomically and physiologically in the brain? Basically, it involves changing individual neurons to the extent that we can develop new dendrites, more dendrites, dendrites that touch other neurons that they weren't touching before. We can change the number of synapses and where they go. We can change the number and the strength of all the connections and decrease other connections, change those as well. So while we can't get more neurons when we acquire new memory, so that as a baby we said we have almost all the neurons we're going to have for our whole life, you would think that if we acquired new neurons for new memory, why our brain would be massively expanding at almost an exponential rate as our learning did, and this isn't the case. We have the same neurons. So we change the way they function, and we change their interconnections. Almost like an operator at the old-fashioned switchboard, just changing where the plugs are going. Now, the entire brain is involved in this process. We talked earlier about how this was a holistic process. If we look at the first slide, you can see that this is a representation of the brain, and the cortex is on the outside, where our neural cells are, the gray matter. And the association areas of the cortex in the frontal, here, the parietal, the occipital, and the temporal lobes are all involved in this. Also involved in this are other areas in the brain called the hippocampus, the amygdala, and at this point I'm going to show you some of these. Don't try to remember them. I want you to have heard these terms, to put them in your memory, but there's too many of them and too much material for us to give in a course. I'd like you to be able to listen to a neurosurgeon, to have a conversation with a neurologist and know you've heard these terms, but you may not remember why. This is going to be short-term memory. We hope you'll be able to recall it for just that. And then as interest dictates, you can go back and look in our textbook and see where these are located. If we look in that area we call the diencephalon, some of this memory is stored there. Also, we have an area you're more familiar with, and those were the pre-central gyrus primary motor area and the post-central gyrus primary somatosensory area. So that somebody learning to play the piano obviously is going to need to call in those areas for touch and for motor function. When a body part is used repeatedly in activities, the representation of that body part over the cortex, remember the homunculus, the little man that Wilder Penfield drew for his map, had representations in both the pre- and post-central gyrus areas, both motor and sensory, that were in proportion to the use of those organs. Thumb was big, tongue was big, back was small. When we learn new motor skills, and a body part is involved in those new motor skills, we actually expand that area on the brain that's involved in the cortex, the representation on the cortex. Now, of all this information that we get, and by now you're clearly cognizant of how much sensory input there is that's unconscious, of what we get coming into the brain, of the total conscious information, only about 1% of it goes to long-term memory and storage. The rest of that is soon forgotten in a matter of seconds. So it's very discriminating, probably because of capacity needs. We can't take in everything. There's not enough room in this computer, wonderful as it is. So we have to divide memory. We found that memory divides itself into several different kinds. The first kind is what's called immediate memory. This is a few seconds duration. It's what we're doing at this moment. You are aware if you're tapping your foot or you're drumming on the table. I'm only aware of that while I'm doing it. A few seconds later, it's gone. I could remember back a minute, perhaps, and remember what I was doing a minute ago, but that's it. It's really useless information. Our body just gets rid of it. It goes in and out. Following immediate memory, we have short-term memory. And this is recalled for probably a few seconds, for as long as a few minutes. So if you tell me a telephone number that I haven't heard before, I can pick up the phone and dial that number. Hang up the phone for a busy signal and I have to dial it again 2 minutes later, I probably won't remember it. I might. Certainly 15 minutes later, I'm almost certainly not going to remember it unless I've made some special effort to do so. So things that I've read or things that I've heard and learned that are used for this very short-term memory probably last for minutes. And as soon as the task is done, it's over. I don't know about it anymore. For the immediate and short-term memories, there are parts of the brain called the hippocampus, the mammillary bodies, which you actually haven't seen yet, that are deep in the underside of the brain, something called the anterior and medial nuclei of the thalamus. And we saw the thalamus down below the cortex in the brain. Just give you a look at that right down in here. Those short-term and immediate memories are handled somehow there. The actual physiology of the immediate and short-term memory probably is mediated by chemical and electrical events rather than anatomic changes. So those changes I talked about with dendrites multiplying and extending to different areas, synapses being modified for the memory, probably doesn't occur, as best we know, in the immediate and short-term memory. This is something that's a short-lived electrical chemical event between neurons. Now, short-term memory at some point can be converted into long-term memory. All memory starts off short-term. And when we define long-term memory, we're talking about hours to years to decades to half a century. If we use the short-term memory over and over again, like dialing the number, like going to an address, then we can recall it more easily when we need it. And it lasts longer. The more we use it, the more we have it available to us. It's a matter of just repetition. And certain pathways are then facilitated to make the recall of that information easier. Now, there's something called memory consolidation. We can reinforce activities that are frequent and they're retrieved from memory over time. It seems to break down to two physical areas in the brain that are different for different kinds of memory. If we have verbal or written ideas that we receive and we need to remember, they tend to be widely spread out over almost the entire cerebral cortex. When I talked about holistic memory, I mentioned that we probably could not excise or ablate part of the brain and get rid of the whole memory. I can't cut out this section and have you forget going to grandma's house for cookies. You'll still have that memory in the rest of your brain, like the holographic picture. Physical activities which require skill, bike riding, diving, ice skating, playing the piano, are primarily involved in the areas that would be most logical now that you've studied the brain, the cerebellum, the area that coordinates balance and integrates all that information for coordinated, purposeful activity, converting intention into productive activity. And also in something you haven't seen yet called the basal ganglia. Now, the basal ganglia are located, as they sound, at the bottom of the brain. They are an important area. You see, here's the cortex. This is a frontal section, correct? The patient is looking at us. He's been cut right down through the top of the head. The face and front of the brain has been removed, and we're looking at the back of the brain. And here are basal ganglia. They have funny names. One is the globus pallidus, one is the putamen, and there's another part of the basal ganglia as well, which we'll get to in a minute. And these are also integrative areas that have to do with purposeful movement. So you would imagine that technical skills might be involved there. The anatomic changes we see when we use light microscopy or electron microscopy, diagnostic techniques like PET scans, positron emitting tomography, have been used in the diagnosis and in the study of brains, and we see certain things. We see an increased number of presynaptic terminals, you know, the little part on the near side of the nerve as the nerve wants to jump its information across to the next nerve. We see an increased size of those terminals. I mean, there's more chemical information getting ready to go across to an individual neuron. We see increased growth of that bulb. What we don't see is any increase in the number of neurons. They are steady in number. They don't vary, as we would expect. So when activities are decreased, you see the opposite. You see a decrease in the number of dendrites, a decrease in the number of connections, of circuitry going on in the brain. And the maxim use it or lose it applies, because those activities which you do a lot, you will stimulate and find more easily. They are facilitated. Now, there are some things that are causes of memory loss very consistently. Anesthesia, even a normal anesthesia that is properly conducted with no complications, can actually have you lose some memory, and that memory may or may not be regained without new exposure. Coma itself, besides just being in a depressed mental state, patients coming out of coma may lose certain memories, both long-term and short-term. We used to have treatment called electroconvulsive therapy. Patients with certain psychiatric disorders, depressions, manic states, were taken to the hospital, electrodes placed on their brains, and they were electroshocked and made to have seizures and convulsions. And one of the things, besides occasionally helping them with their illness, was they lost a lot of memory. And then other disorders of the brain, poor blood flow to the brain, ischemic attacks, strokes will also obviously hurt memory. Attached to memory, almost the antithesis of memory, is amnesia, loss of memory. And that loss can be what's called circumscribed or retrograde. When you're hit in the head and knocked unconscious, let's say boxing, you will probably wake up very quickly and not remembering the events right around that period. That's called circumscribed and sometimes retrograde amnesia. You won't remember the events just before. You may not remember the beginning of that round of fighting, and it may never come back. Complete amnesia, the total loss of memory, the kind you saw in the wonderful book by James Hilton, Random Harvest, where the hero lost his complete memory for some part of the book because of trauma, is very, very rare. That's a rather unusual. Most doctors who deal in this don't ever see one of those in their whole lifetime. But the circumscribed amnesia is much more common. And in fact, what's interesting about it, when you lose that memory and then you regain it, you regain the most recent events last. The farther back ones come in first, and whatever you're going to regain comes back in a temporal chronological order. Now, you're probably sitting there saying, this is awfully descriptive and very vague, and the answer is yes. It is very descriptive and very vague. We're just looking at a subject and describing it and trying to be very scientific in a subject that just isn't all that scientific yet because we haven't got the information. Very hard to study. We can use words, but we're getting more and more machinery that allows us to look at the brain while it's functioning, like the PET scan. But we have a long way to go in this, and animal studies just aren't enough because we have certain abilities beyond animals, or beyond what we can detect in the animal. The animal can't communicate this to us. So other than studying rats in mazes, getting it to the human level is very, very difficult. That concludes some of the normal things we're going to talk about. I'd like to go on and tell you a little bit about some of the defects in the brain and in the nervous system, because they bring together in a really nice way what you've learned about normal anatomy and physiology, show you how things can go wrong, what they might look like. One of the areas that is very interesting are cerebellar defects. The cerebellum is our center of coordination. It's intention. There's something called cerebellar ataxia, which is our inability to walk or balance. When the cerebellum is injured, for whatever reason, it may be trauma, a blow to the back of the head. It could be alcoholism, very common in injuring the cerebellum. Could be ischemia, lack of blood flow. We get a very typical response. We get something called ataxia. First of all, the patient is unable to walk very well. Walking is a very highly coordinated activity requiring balance and coordination and a lot of feedback. So this is not done. Patient staggers, falls over. Their speech is slurred. The organs of the tongue, the lips, the vocal cords, highly coordinated in normal speech. So this patient staggers, has slurred speech. They have something actually more interesting, and it brings us to our next subject, so I want to get it and discuss it here. It's called intention tremor. When I take my finger and try to touch my nose, and this is the test we use for the patient, I'm really never initially going to head straight for the nose. I might be heading over this way, but the cerebellum detects that and makes a correction. And it corrects away from the wide swing to a little bit to the other side. It may overcorrect a little. And I'm exaggerating this, but basically what may happen is we zero in. I can touch myself in the nose every time, right on the tip, eyes closed. because the cerebellum is making micro corrections. Now, you're only seeing my finger go straight, but it probably actually went in an arc. A patient with cerebellar ataxia doesn't have that correction ability. And what the body does without the cerebellum to coordinate it is, the intent is not executed. What happens to that patient will miss the direction, and then the cerebellum will overcorrect and overcorrect until the intent is wild variations and fluctuations, so that I don't poke myself in the eye. If I wanted to touch a point out here, the patient with cerebellar ataxia would do this. The closer that patient got to the target, the worse it would be. Might even actually start off with only a little deflection, but it would get wild. And this is called intention tremor. Vacillations or variations in movement is a tremor. You've seen people whose handshakes, head shakes, those are tremors. And that tremor, intention tremor, is classic for the cerebellar defects. I mention it first, not because it's very common, because it's the exact opposite of what happens in another series of disorders, disorders of the basal ganglia, and namely of Parkinson's disease, which is probably the most common and well known to you. The basal ganglia, as I pointed out, are back here. The basal ganglia are located at the bottom of the brain. It's a bad term. We shouldn't call them ganglia or a ganglion. Ganglia, by definition, are swellings in the nervous system due to the presence of lots of neurons outside the central nervous system. So we saw the ganglia of the sympathetic chain, we saw the parasympathetic ganglia, we'll see more ganglia in this course. But when they're inside the nervous system, they should be called nuclei. However, they're not. That's not what anatomists do. They still call them the basal ganglia, so we have to do that too. And they are called the globus pallidus, as I said, the putamen, and the caudate nucleus. And they're located here and on cross-section here. Now, what these do, these are involved in body, again, coordinated movement, but not entirely related to the cerebellum. In Parkinson's disease, which was described in the early part of the last century, it's a disease that affects elderly people, generally over the age of 60. By far, the vast number of patients are over the age of 60. There are exceptions. Muhammad Ali got his Parkinson's very early. Michael J. Fox got Parkinson's disease at a very young age. It's very tragic for these people because certainly in Ali's case, it has ruined his career and his life in many ways. It was thought years ago that we saw a very big rise in the number of these patients, and we thought that what was ever happening to the brain was related to the late effects of the great influenza epidemic in the early part of the 19th century, that the brain was damaged, and then we saw this whole bunch of patients. But it's not thought necessarily to be that. There are lots of things that may injure this part of the brain. We're not sure exactly why it is, but that bump in the population may have been due to the influenza epidemic. We will never know that. What happens here is there are neurons in an area of the brain called the substantia nigra, the black substance. You are down in the brain stem, and here are the tracks that are coming up into the brain, and there's this area that's black, substantia nigra. This area releases a neurotransmitter. We've seen two neurotransmitters. We've seen acetylcholine in most nerves synapses, and we've seen epinephrine, norepinephrine in the sympathetic system. This one is called dopamine, and this neurotransmitter goes to the putamen and the caudate nuclei of the basal ganglia, and the result is a net lowering of that dopamine and an increase in the other neurotransmitter called acetylcholine, which is a bad thing there because it doesn't belong there. So there's an imbalance in these two chemicals, and it causes a very specific syndrome that has several characteristics. It causes something called a waxy paralysis. We know that when we denervate muscles in the body, they tend to become flaccid. They have no tone. This is a paralysis because the tone is too great. The muscles are in constant spasm and tightness, and they can't move so well. It's called waxy paralysis. It results in a very characteristic picture. Most experienced neurologists or doctors can walk in a room, look at a Parkinson's patient, and make the diagnosis from the door. They all look the same. They have what's called a masked facies, or a masked face. Their muscles are so tight that there's almost no expression. They have trouble smiling, frowning. The face is just one rigid picture that doesn't change with the changing conditions. They have decrease in their voice power because, again, the muscles of phonation and respiration are rigid. They have something called micrographia. They write in very, very tiny letters with a shaky hand because they can't make the big movements that they need. They have kind of a wide, unblinking stare. They do some drooling because they don't have control of some of those muscles. And their movements are very, very slow because of the spasticity. They have a decreased range of motion in their limbs, but the most common characteristic, the one that everybody remembers, is the pill rolling. They sit there with their hands in their lap and they roll pills, both fingers. And other muscles may tremor too. Whole body begins to shake in a very small, rigid way because they can't make big movements. This is the opposite of the intention tremor that we saw with the cerebellar ataxia. The Parkinson's patient has a rest tremor, very typical of basal ganglion disorders. That patient sits there rolling the pill, and the tremor is at rest, but as soon as he starts to comb his hair, the tremor goes away. And the patient can write, whereas the ataxia patient would start to make that pen and the hand would go all over the paper, wouldn't be able to write at all. Parkinson's patient can write with difficulty. But this is a tremor at rest, and for physiologic reasons in the basal ganglia, goes away with intention. So the patient could express intention. The problem is the paralysis, the spasm of the muscles, not the coordination to make that intention become action. Very interesting disease. Now, we spent a lot of money and a lot of time trying to do things for the Parkinsonian patient. We've tried to increase their dopamine levels and decrease the acetylcholine levels medically. But remember the blood-brain barrier that we talked about? We have trouble getting dopamine into the brain. If we give the patient a pill that's absorbed into the bloodstream and circulates, dopamine doesn't cross the blood-brain barrier very well. So we've engineered this to find a dopamine precursor chemical that does cross the blood-brain barrier and might be converted into increasing levels of dopamine for the patient. Unfortunately, this is a progressive disease, and it seems to get worse with time, and the dopamine eventually does not help. Neurosurgeons are trying to transplant engineered cells that produce dopamine by placing them in the substantia nigra and hoping they'll grow. They've been doing this for years. It's not been highly successful yet, not to say that it might not be. And there were surgeons in the past that tried to destroy the globus pallidum in the brain, and that part of it which affected that particular patient's Parkinson's. Some patients have it in part of their body. There was a well-known surgeon who had something called a stereotactic device. He had the head fixed in a grid, and just like Wilder Penfield, he would make a hole in the brain and insert a needle down into the globus pallidum with the patient awake and tremoring. And then what he would do, rather than just destroy something and hope for the best, he would blow up a balloon and start compressing that part of the brain. Nothing happens. Move his needle, put it in another part of the brain nearby, blows it up, and the tremor goes away. Tremor stops. He knows he's in the right spot. He can then leave the needle in place, deflate the balloon, inject a chemical, inject electrical current, something to destroy the brain, all kinds of ways. One way was to freeze the brain at that point and see if the tremor went away, and if it did, lower the temperature even more to destroy the cells. So you could do temporary changes. Lots of technical attempts to take care of this disease. So far, it's still a very difficult disease to treat, makes life very difficult, and these patients have a hard time because they are fully cognizant. Their cerebral cortex is working perfectly. So they have a very bad neurologic disorder, and they're fully aware of it. This is unlike Alzheimer's disease, or technically called Alzheimer disease. In Alzheimer's disease, one of the comforting things I was told recently by a neurologist, I mentioned to a friend that I'm really getting absent-minded, I'm forgetting things all the time, I just know I'm getting Alzheimer's, and he says, you don't have Alzheimer's. I said, why not? He says, because you're worried about it. Patients who have Alzheimer's disease are not aware of the disease at all. They don't know that they've got a problem. They're blissfully ignorant. They actually have a lot worse symptoms because this is progressive and fatal. But unlike the Parkinson patient, the Alzheimer patient at least is protected to some degree by the knowledge that they have this awful disease. So those are diseases of the basal ganglia. Let's move on now to another disease that brings us into some ethical problems. And this is a disease called Huntington's chorea. It's an inherited, genetically dominant gene. So that means you only have to receive one gene from either parent to get this disease. Talk about the genetics in a later chapter, but just remember, it's easily transmitted. The problem with this disease is it is not selected against by natural selection. Evolution plays no part in getting rid of this disease because it doesn't occur until the patient is 30 or 40 or 50 years old in many cases. So that patient is already reproduced. Keep in mind through the whole course that natural selection, pressure, and evolution only functions on things that affect the outcome before reproduction. Once you've reproduced, there's no pressure from natural selection. So Huntington's is a bad one. It is called Huntington from the doctor, but chorea means dance. And these patients have rapid, jerky, purposeless movements of the extremities and the head that they cannot control. They have accompanying progressive mental deterioration, and it often takes 10 to 20 years to kill them. So there's a very long period of time where at first they have this awful uncontrolled movement, they then have mental deterioration, and then they finally die of the disease. The ethical problem we get into is the area of genetic counseling. We can detect this gene. So in families where there now has been known to be a history of Huntington's chorea, we advise patients to get genetic testing and then have to make a decision whether they want to take a chance. But 50% of the offspring of a carrier of this gene is going to have the disease. And they're going to have that gene and be reproducing before they might get the disease. So fortunately, we do have the ability to detect it genetically in time to warn someone. And it's a matter of counseling and advising the patient to make that decision. Another injury, moving away from some of the upper brain, are injuries of the spinal cord. Very, very common because we live in a high-speed society and a violent society. We have lots of injuries to the spinal cord from automobile, plane, train wrecks, from knife and gun wounds, from blunt trauma, also tumors. There are tumors inside the cord that can compress the cord and sever its blood supply or its function from the brain. We talked about herniated intervertebral discs that can fly out and injure the cord when they're pressed, and blood clots can get to the blood supply of a cord and transect it. I'd like to just define some of the kinds of paralysis you get because you hear these words so often. Again, I'd like to put them in at least your short-term memory so that you'll know what they are and you can look them up again, knowing at least you've heard them here. First of all, we have something called monoplegia, which merely means one extremity. Plegia is paralysis. Paresis is weakness. You can have a monoparesis, weakness, or monoplegia, paralysis. Monoplegia is one extremity. That would come from a solitary area in the brain, or it might come just from the nerves leaving the cord or going through the armpit, for example, to the arm. Diplegia means two extremities. Those two extremities excuse me, are usually on the same side of the body. Now, paraplegia occurs when the body has a diplegia on both sides of the body. It's almost always below the level of the abdomen because the nerves to the lower portion, to your legs, come out at about the level of the abdomen and below. So transecting the cord above that would create paraplegia, parallel limbs on both sides of the body. And as you go higher and higher in the body, you start losing more function. If you transect the cord in the neck at a certain level, you will have something called quadriplegia. All four extremities are paralyzed below the level of the injury. Now there you get into a very tight situation because you're starting to get to the level where the nerves for respiration, the phrenic nerve, comes out of the cord and down into the body. If you injure that, that's near the level of the top vertebrae, near C1, then the patient not only is quadriplegic, but can't breathe. They would require artificial or supported respirations. Patients who are quadriplegic have usually full function of their head and all the functions above the neck, but, for example, would have a little difficulty with speech if they have difficulty with respiration, because they have to get the air up and out of their lungs, and this may require quite an effort depending on how much of the chest has been denervated. And then we have something called the hemiplegia, which is different. That refers to one side of the body or the other. And hemiplegias are usually a problem up in the brain rather than down in the cord, because the separation takes place in the brain. Remember, the right side of the brain in muscular function crosses over from the neck down to the left side of the body, and vice versa. So injury, stroke on the right brain would cause a left hemiplegia or a hemiparesis, depending on how serious it is. The next syndrome is called the Brown-Séquard syndrome, named, of course, after Dr. Brown and Dr. Séquard. And this is a fascinating syndrome. It's not too common, but it's a wonderful explanation of anatomy. In the Brown-Séquard syndrome, you have a partial or a hemisection of one side of the spinal cord. This is most commonly either vascular, or the only one I've seen in my career was an knife wound that went into the cord between the vertebra and severed one side of the cord. I've seen a picture in a journal of a broken arrow tip that was on one side of the cord. If we go to this slide here, we can look at the cord. It has been sectioned here. And if you imagine cutting one side of the cord and leaving the other side intact, you can see what we would have. And you remember now where things cross over. If you injure the posterior columns back here, this is sensory input, right? Here's the fasciculus gracilis and fasciculus cuneatus, which I know you remember from several lectures ago. And this gives us loss of proprioception and fine touch on the same side of the body, because these columns don't cross over in the brain. So if this patient had a left-sided injury and the proprioception and fine touch were coming up these columns to the brain, that patient would lose that function on the left. If you injured the lateral corticospinal tract, for example, it's a little hard for you to get oriented because they're showing motor and sensory on different sides. But now let's look over this side, the lateral corticospinal tract. This carries motor fibers. And so this would be on the same side of the body down here, because we haven't injured it in the brain. Remember, if you had a stroke, you'd have to have the stroke on the left brain to paralyze the right body. Down here in the cord, you're going to have your paralysis on the same side. And then finally, if you damage the spinothalamic tract, which is down here and down here, these are sensory, you would lose pain and temperature sensation on the opposite side of the body, because there is a crossing over in the brain. So this Brown-Séquard syndrome, though it doesn't happen very often, is really a nice physiologic example of what someone can see and a diagnosis you can make without having to do a CAT scan. I mean, you can examine this patient, do a careful anatomic examination, and know exactly what's going on in the body. When you injure the spine, and especially after a complete transection, you cut the cord in half, you have something called spinal shock, which is immediate. Lots of things happen to this patient. Their blood pressure will drop. That's probably because we have now severed the connections that cause regulation and constriction of blood vessels to those capillary beds we talked about in the very beginning that help support the pressure. The entire lower half of the body will now be open to all the capillary beds, and the blood pressure will usually drop. There's areflexia. If you tap on the knee and the injury involves that area, there won't be any place for the spinal arc to go. And even if the spinal arc is intact, the body doesn't respond. The cord itself is in shock. There's a flaccid paralysis. The limbs are limp. There's loss of sensation everywhere below. There is loss of bowel and bladder function, so this patient is usually incontinent. Later on, the reflexes will return, and you may go from a flaccid paralysis to normal tone, because the brain can take over a little bit, although it can't get its impulses all the way down the cord. The cord itself, the lower reflex arcs, will become intact once again. We talked a little bit about anesthesia. I've spoken to you in the past about general and local anesthetics. Basically, just remembering that in a general anesthetic, we're really anesthetizing the reception of pain impulses. The upper brain, the waking centers, and all the sensory areas of your superior brain are anesthetized, are asleep, and although the pain impulses are going to the brain, you're not aware of it. There's no reception. In local anesthesia or regional anesthesia, no pain impulses are going to get to the brain. You've placed a drug in the way of the nerves, whether it be the spinal cord or the peripheral nerves, that does not allow transmission of that electrical impulse up the rest of the way to the brain. So the patient can be awake and does not perceive pain at all. Okay? The other thing in anesthesia we have talked about is respiratory depression, so I won't go into that again. Let me talk just for a moment about referred pain. There's something called referred pain, and this is caused by having the visceral organ, the organ inside the body, following the same sensory nerve as the part of your skin is sending to the brain. Remember, we divided the body up into dermatomes, slices where each sensory nerve went through a different lumbar, thoracic, or cervical level. We called them C1, 2, and 3, and so on. And the body is composed of stripes. And I know that if I touch a certain part of my thigh, that would be carried up through, let's say, S1 and L5. And the arm is carried through fibers in the neck. Now, sometimes the fibers from your organs have to travel in those pathways too to get back to the brain. And there is some confusion on the part of the brain. For example, if you look at this next slide, the shoulder is at the same dermatome and carried in the same fiber as the area under the diaphragm. If you rupture your spleen and accumulate blood under the diaphragm, that sensation is going to feel like left shoulder pain. The heart pain fibers are carried in the same bundle as the left arm. Patients who have a heart attack feel like they have pain in their left arm. The brain is not able to tell the difference. And it gets very specific. Gallbladder pain tends to go around the side and up to the back of your shoulder blade. Whereas pancreatic pain, which is very nearby, tends to go straight through to the back. And they're very, very different. You can get pain, for example, of appendicitis, which is rather interesting. The appendicitis starts off with pain around the belly button, and then over time goes on down to the right lower quadrant. It doesn't usually start in the right lower quadrant, and I'm going to save that for when we talk about the appendix. So these are just a handful of the myriad of things that can go wrong with your nervous system, how we correct them. And the next lecture, we're going to move on to a whole new system. We'll begin 7 lectures on the digestive system.